Welcome to the Neurocrush Immersion. In this episode, we are going to talk about the pain of conscious experience. And we have with us a very eminent neuropsychiatrist and researcher from the National Institute of Neurology and Neurosurgery in Mexico, Dr. Jesús Ramírez Bermúdez. Welcome, Dr. Jesús, and thank you for joining us on the podcast. Would you like to tell us a little bit about yourself?
Yes, thank you very much, Dr. Krish. And about myself, I am a clinical neuropsychiatrist working in the National Institute of Neurology in Mexico, working with the scientific problems and the clinical realities. I also found out that these perplexing cases would motivate me to make a reflection on it. So this kind of personal reflections led sometimes to literary work on one hand, and also to an interest for the history and philosophy of our own disciplines. So broadly, that is my kind of work.
In your own experience, have you had got to a point where the objective data that you're beginning to encounter requires you to reevaluate the subjective interpretation that you've been working with the patient?
Could you elaborate a little bit more, or put an example so I can understand better the question?
Oh yes. So when we work with someone and we're listening to their story, their narration of painful conscious experience, and we are developing this clinical picture of them in our heads, that this is what is wrong with this, or this is where they are, this is why they're having problems. But then you might get an objective piece of data, like for example an autoimmune result or a imaging result, which kind of seems contradictory or different to what you've been working with all along. So has that happened to you? How do you rationalize that? How do you work through that conflict or challenge? Because we often share with patients our perspectives. So for example, if we have shared some psychodynamic perspectives and we are working on that, and then now here we have suddenly a piece of data which is at odds with that perspective that we've been working on.
Yes, it's a great question. Because, of course, I use the resources of psychological formulation, through the resources of psychotherapy and so on. But I remember now a case that aligns with your question, in which this was a woman, a female doctor, who was very problematic in her own workplace. She had this kind of emotional dysregulation, was seen by her colleagues as being a case of borderline personality disorder, with a lot of these mechanisms of high idealization and then devaluation and emotional conflict and so on. So that was the picture of the patient. I was trying to help her through the resources of psychotherapy and so on. And I had a kind of hypothesis that all of this was caused by the dynamics of the patient with their fathers in early development, because I even had the opportunity to meet the parents. So I had my hypothesis, that was in a way informed by psychodynamic theories and even behavioral theories, and the kind of approach that we make from the psychological side. But then some facts led me to think about the possibility of a neurological disorder, because she had episodes of severe headache. So we made a MRI, and in that case I found out that this person had a lot of white matter damage, specifically in the orbitofrontal cortex, in both hemispheres, but most severely in the left hemisphere. And so we didn't have a precise etiological explanation for those lesions, but they were located in a very strategic way to explain these problems with emotional dysregulation and so on. So my understanding of the case changed a lot. Now I still regarded the psychological explanation as valuable, but I could not ignore the facts that were brought by the magnetic resonance imaging. So now the functional explanation would need to use these resources as well. And I wonder, because I was not in her own workplace, right? I only interacted with her. But I wonder what would the other physicians in her workplace, what would be their own judgments and thoughts and relational approaches after knowing that some of her behavioral problems were at least partly explained by a neurological disease, as opposed to being explained only through the resources of the interpersonal explanations, right? Because as persons, if our colleague gets angry, we get angry and we start building a narrative, right? That she's a horrible person and so on, right? But if there is a neurological explanation, perhaps the interpersonal approach changes, at least for some of her colleagues. But I don't have an answer to that. I can only think that that kind of problem leads us to approach the nuances of free will and so on, right?
Absolutely. And I think that's very well put, because in a sense, when we see a structural problem, the MRI finding, for example, we suddenly develop empathy to what the person is going through. But the lived experience is a painful one, no matter what's causing it. And of course, we both know that just because you can't see something structural doesn't mean a problem that explains it from a functional neuroscience perspective does not exist. And this is also something that even we have to persuade ourselves as clinicians to remember. Somehow our empathy is greater when we are able to see causality, biological causality, as opposed to when we are dealing with just what we assume is just psychological responses. I'd like to share an experience with you and ask you some questions with regard to that. Because there are some inherent tensions between these three things: the neurobiology that our neurobiological understanding and knowledge that we use, the clinical classificatory systems in psychiatry that we rely upon, and the lived experience of mental health that our patients are relating to us. And very often we have difficulty in bringing these three things together in a number of situations. So I have this person who I started working with 21 years ago. And I have spoken to her on average about once in 15 days for 21 years. And I've spent time trying to understand why this extraordinarily intelligent, very sharp, very intelligent young woman has so much difficulty with relationships, why she is so hypersensitive, why she is so hyper emotional, and why her expectations of people and of relationships and of situations is so often off the charts that she gets hurt. So this is something I've kind of tried to get my head around for years and years. And of course, when other clinicians have been involved, terms like borderline personality disorder and various other categories have been proposed, but I never could persuade myself that the person actually fitted well into any category. Now, my own understanding and experience of neurodiversity has grown in the last few years. And it was only maybe a couple of years ago that the penny dropped, that I'm actually dealing with someone who's a very high functioning neurodivergent individual, in whom hyper emotionality, hyper linguistic communication, hypersensitivity, focusing on certain very specific things are the norm. And this, of course, has greatly influenced the way I was thinking about the person. So I want to pick your brain on this, that how do we resolve these imbalances when we work with people? When neurobiology, clinical classification, and lived experience don't seem to match with one another. As a clinician, as someone who places great value on a systematic approach and lived experience, how do you resolve this?
Yes, it's a great question and a very interesting example, because I think what you are highlighting is that we have many tools to make sense of the clinical problems, right? We use the resources of empathy and intersubjectivity and interpersonal resources. We use the tools of rationality, rational communication, dialogue, and so on. We use the resources of taxonomy, the resources of neurobiology, the resources of behavioral psychology, and so on. And most of the times, all of these different tools allow us to make a synthesis in which we feel that there is coherence, internal coherence between all the sources of knowledge, right? So then we feel very confident that we are into something. We have an important clue to start working with the person, right? In a direction, whether we decide it is a case of schizophrenia or a case of bipolar disorder or a case of Parkinson's disease or whatever. So we feel this internal coherence, this logical coherence between all the sources. But what happens when we feel that there is no coherence between all the sources? So we have, I would call it, an epistemic feeling ourselves, an epistemic feeling of uncertainty that something is wrong, something doesn't fit in the picture. If the model of the case were perfect, we should not feel this kind of unsettling epistemic feeling that something is wrong. So I think we need to be very sensitive to those epistemic feelings, because, like yourself, you're an expert clinician, a person with a lot of experience, who is careful to approach their own patients in a multidimensional way, and yet in this case you felt that something didn't match with the pattern that was proposed, right? Like the borderline personality disorder or whatever. And then sometimes the scientific community develops new concepts through research, like this spectrum of neurodiversity with different phenotypes related to autism, high functioning autism, and so on. And perhaps that knowledge, that information improves your model and then allows you for a new approach, whether it's psychotherapeutic or pharmacological or a different kind of approach. But I think that is a wonderful case of how our clinical understanding needs to remain open to new concepts in a way, but also to this epistemic feelings of knowing and uncertainty, I think that some clinicians prefer the dogmatic way, because feeling uncertainty is uncomfortable for us, right? It is not nice feeling that you don't know what's happening with your patient. So some prefer the authoritarian, the dogmatic way. Sometimes there's a lot of social criticism to psychiatry, because those kind of clinicians who are very authoritarians and dogmatic, but I think that that's not the way for us. I think that we need a lot of once again I will use this word, no, like epistemic humility, to acknowledge that we don't know many things. But this is not only for psychiatry, it's for the rest of clinicians in the mental health professions, because we really don't know the answers to a lot of very distressing problems. And of course, borderline personality disorder is perhaps in the core of this problem, right? Because we have approaches. It's not like if we don't know anything. We know a lot of things about this problem, but we still haven't figured perhaps the central clues that would lead us to a scientific discovery or a scientific full explanation of these cases that will allow us to more effective treatments. So having said that, I need that we need to remain with a lot of epistemic humility, not only in psychiatry, but in the whole mental health field. We can't explain everything with trauma. We cannot explain everything with a reductive neurobiological factor. So we need to remain open. We need to consider all the alternatives, and most of all, listen to the lived experience of our patients without a preconceived dogma. That would be my approach to this problem. Thanks a lot, Dr. Krish, for these questions. I really enjoyed this conversation with you.
Thank you so much. I mean, you're bringing so much light into the entire thought process. I have two questions which are kind of relevant for young professionals working in mental health. The first is there such a thing as epistemic blindness, or being epistemically agnostic? And how do you prevent that? Because I mean, everyone needs to learn not to ignore a very important aspect of lived experience, narrative experience, and the synthesis that we need to absorb from there when we think about our patients. So that's my first question. And my second question is, people are working with limited periods of time. It's a huge problem. So how do you integrate this kind of work into your practice within the constraints of time? Because I'm sure you have a busy practice, and time is finite. So and young people, that's a huge concern. When they work in mental health, it's a huge concern as well. So yeah.
No, I totally agree. So first, I think that if we acknowledge that we have blind spots, in our own approaches, that can lead us to prevent this kind of epistemic blindness by working with a team, right? That's what I usually do, teamwork, right? Because I cannot see my own blind spot. I need somebody else to see it. So I think that building teams in clinical practice is essential. And the other point would be a larger concern that has to do with scientific discovery. For instance, the problem of anti-NMDA receptor antibodies, we were epistemically blind to that problem years ago because there hadn't been the discovery. But the problem was that we had some dogmatic approaches to those cases. So some clinician would tell me, this is a viral encephalitis, period. And I would say, but we didn't find the virus. Doesn't matter. It's a viral illness. And other clinicians would say it is a case of primary psychiatric disorder, period. But why? If it doesn't make sense, etc. So I think that scientific discovery will prove us wrong in many cases, but we need to acknowledge that we have limits in our knowledge. We need to have that sense of metacognitive acknowledgement of our own errors, our own blind spots. I think that teamwork can prevent, at least partially. But the other approach would be acknowledging what I don't know and explicitly reflecting on it, making a analysis of those regions of uncertainty, because it can lead us to scientific discovery, or at least it can lead us to a reflection in a positive way, right? Instead of choosing the dogmatic and the path of the authoritarian clinician, right?
Absolutely. The other thing I'm thinking about is that we get into this challenge of, for most of us, it's the context in which the narrative experience is presented to us is the pathway that we go down very often. So if someone, for example, does not bring to our attention any biological causality reasons at all, and is talking largely about lived experience, our time is spent trying to make psychological and psychodynamic interpretations. So I have, for example, people who present with FND, functional neurological disorder, and they're talking about a number of symptoms. And then at some point in time, and they neglect, for example, to mention that all this started after a bout of COVID-19. So in a sense, you're spending a lot of time thinking about psychosomatic symptoms, psychosomatic interpretations, and so on, and you're not thinking biological at all at that stage. And it takes a critical piece of information for you to then start thinking biologically. So, in clinical practice, I completely agree with you that multidisciplinary work helps a lot, because what you fail to pick up, someone else will, and what they fail to pick up, you will, and you in a good team, you complement each other. So I completely endorse multidisciplinary assessments and multidisciplinary work as a way forward. We do it all the time. It's very much part of the kind of work we do in Buddhi Clinic. But at the same time, the narrative can blind us to biological causality sometimes. And how do you sort of, make sure you don't get into this trap of meaning that we are being drawn in?
Exactly. In our own paper, we discussed this problem of the trap of meaning that was being conceptualized by Dr. Kenneth Kendler in a former paper. So I think we need to be cautious and aware of that possibility, because narratives are very powerful in the sense that they make us feel confident that we already understand the problems, right? The cognitive process of narratives provides sort of rational closure in which we think that we already understand the reasons and the motives, and sometimes we can even broaden our understanding to include in this narrative framework some symptoms or some processes that perhaps don't fit there. In the case of, for instance, of long COVID, some patients will have episodes of dysautonomic problems, right? Like syncope, for instance, and others. And we still will try to make psychodynamic narratives of what could be the unconscious motives for that kind of symptom, when perhaps there is a completely different explanation and treatment underway. So narratives are very powerful, they are very helpful, but they can lead us to the trap of meaning. So that's why I think that we always need to keep our critical thought open and working. So a bit of uncertainty is helpful for me in clinical practice, because when I feel excessively confident, I will usually make more mistakes.
Absolutely, I couldn't agree more. You also talk about anosognosia, where patients lack awareness of their illness. And, how does a trans-epistemic approach guide clinicians in dealing with this particular problem when the patient lacks awareness or is in denial of their own illness?
Exactly. Now, the kind of patients that we see with anosognosia usually have severe neurological disease, like a vascular disease leading to stroke, or sometimes neurodegenerative disease and others. But my point here in the case of anosognosia is that I think that the current efforts to build a science of consciousness, a neuroscience of consciousness, need to focus on that kind of clinical phenotypes. So perhaps here we have a different kind of lesson to be learned, because the lived experience of the patient is that, for instance, they don't have blindness, when objectively they do. So what the case teaches in the case of anosognosia is that the blind spot of the patient can worsen due to neurological disease in such a way that the patient has a severe loss of their own metacognitive abilities, leading to this discourse, that the patient can see and he wants the keys of the car to drive in the highway when it is a blind person, right? What can we learn from it? Well, I think that we can learn a lot, and I wish that researchers, neuroscientists, neuropsychologists, and so on, that are nowadays working in the scientific approach to consciousness, try to explain these problems, right? Because this is people in distress, these are families in distress, and we need to provide a two-way approach from the clinical practice to the scientific models, and from the scientific models to the clinical practice. Sometimes I see some kind of divorce between basic neuroscience and clinical neuroscience. So I wish that we bring them together. And I think anosognosia is one of the core problems in cognitive neurology, and can teach us a lot about the nature of awareness.
Thank you. You've talked a lot about the painful nature of conscious experience. How can this be integrated into mental health policy and how we work on the larger scale of things?
Well, perhaps the problem of suicide would be one point of departure, right? In the sense that, what I mean is that the problem of suicide, if one looks at the epidemiology of suicide, the public health aspect of it, is a way to have a diagnosis of the public mental health resources and the problems leading to mental health problems in a specific community. But of course, counting the number of suicides is already too late, right? It's already too late. So we need like a different kind of measurement, a different kind of tool to prevent that. So acknowledging the phenomenological dimension would be key in my approach to preventing those long-term outcomes or fatal outcomes like suicide, but also perhaps the relationship between this distressing mental states and the lack of social functionality, disability, and so on. So what I would argue is that we need a shift in medicine, most of all, towards a larger acknowledgement of subjective experience, lived experience, in the context of medicine. And at the same time, I would say that mental health professionals who are usually aware of this phenomenological experience need to pay attention to the other side, the objective side of it, the neurobiological dimension, the physiological dimension. So, because nowadays I think there is a divorce between this, right? So we have approaches that only focus on lived experience and trauma and so on, and on the other side we have only reductive approaches. So we need to bring them together. That would be my message.
Thank you. My last question. There's often a dissonance between how we conceptualize the problem the person is going through and how the person conceptualizes it themselves. And of course, especially in mental health, people kind of latch on to things that you say and may sometimes pay disproportionate value to even something that you say in passing. How does one ensure that one protects the patient and ourselves from such dissonance being expressed? And how do you ensure that when you work with people, how do you ensure that you don't inadvertently put a thought into their mind which is dissonant from what they themselves are conceptualizing?
Exactly. So if I understand you correctly, sometimes the clinician has an explanation of the case, with the resources of a taxonomy or a neurobiological fact or a clinical concept. And at the same time, the patient has a different experience coming from their own history and insights and introspections and their conversations with popular culture and so on. So how do we bring them together without silencing, in a way, the lived experience of the patient, without artificially solving a conflict that is still there? So, well, what I usually do is explore the not only the subjectivity, but the explanations, even if it's a popular psychology explanation or a cultural explanation or whatever. I explore the explanations of the patient for their own problem, right? And then I start making my own approach of the kind of explanation that I have. Instead of just imposing diagnosis or whatever, I try to think on what are the advantages of their explanation and my explanation for the purposes of the patient, for their own values, for their own functional integration with society, for their own psychological well-being, and so on. So I think this kind of dialogue, which is in a way, Socratic dialogue, or in a way, it is a dialectic process, needs time and openness on both parts. So sometimes we will deal with the rigid mindset of a patient, and sometimes ourselves we are not open to the explanations of the patient. And so I think there is a negotiation coming along in the way in these dialogues, and we need the art of persuasion, which needs to be a genuine ends for persuasion, and we need good reasons to change the mindset of the patient. And sometimes that takes time, right? Sometimes we need to let the patient go in their own way, and perhaps then they will accept a different explanation. That happens often in bipolar disorder, don't you think? It is very common that patients with bipolar disorder will go their own way, not using lithium or the medicine that you prescribe, and perhaps later on they will accept that explanation. But we didn't. I never tried to force an explanation, right? But however, we need to be rational, and to, after a good deliberation of the case, we need to be clear with the patient. What are the risks and advantages of each kind of explanation?
In fact, while you were speaking, I was remembering this patient I saw recently for the first time. Well worked up by my team. Case of complex partial seizures on 2 new anti-epileptic drugs, had stopped having seizures. And the only thing he was reporting was a lot of anxiety. And talking to him and breaking it down, my very strong feeling was that it was ictal anxiety. And it was not circumstantial anxiety driven purely by circumstances or psychosocial factors. But whatever I said to him, I found it very hard to convince him that what you need is better control of epilepsy. I offered to support him with CBT. I offered to, support him in various ways. But what I was trying to persuade him was that, your medicines are working well, but they need to work a little better. And perhaps an amplification of the dosage will do the trick. Your anxiety, and how much ever I shared a biological explanation that anxiety comes from the same parts of your brain where your epilepsy comes, and when you have subclinical activity, it can manifest as anxiety. All this, we ended the consultation not being in consonance with each other. We ended up feeling a little, I certainly terminated that feeling a little dissonant, that this didn't go as well as I would have liked to. And I suspect that he felt the same way. And I think this is part of how he perceived his lived experience, and how my explanation was not consonant with his lived experience. And I guess, all the years of experience we have, and all the knowledge or skills that we have, sometimes we just fail to come onto the same page, or to bring someone on the same page. And I completely take it from you that possibly we need to allow this person his space, meet him over and over again if he will, and hopefully at some point of time we will achieve a greater degree of consonance between each other.
Exactly. I totally agree, Dr. Krish.
Thank you so much for your time. It's been wonderful talking to you. And I think you've shared so much today about the narrative of painful conscious experience, and how that links with modern science, how that links with clinical psychiatry. It's been most insightful. Thank you so much.
Thanks to you for this opportunity, Dr. Krish.
And those of you who've enjoyed this conversation, please do like and follow the podcast. And we are on Apple, we are on Spotify. If you'd like to watch the visual version, you can watch it on YouTube as well. Great being here today, Dr. Jesus. Thank you.
Bye.
Bye. So before we close, I wanted to say, we are organizing this AINA meeting, 12th and 13th of December.
In Chennai.
It could be either Chennai or another central Indian city called Indore. We're sort of debating because of the weather in Chennai at that time of the year. So we're kind of debating that. Do you think you'll have an opportunity to come over? Is that at all possible?
Yeah, I think it will be difficult because this year, in the September, October, November, December, I have already a lot of yeah, of events in which I need to be in Spain and here in Latin America, many places. So I think this time it will be impossible, unfortunately, because I've never been in India, and I really I'm looking forward to go there someday, but it hasn't been possible yet, Dr. Krishnamoorthy. So sorry, but I don't think I will be there.
I completely understand, but please take this as an open invitation. I think we'd love to have you come and spend some time with us. We'd be, we don't have money for airfares, but we look after you while you're here. So anytime you feel you can make the trip, please think of, our organization as willing hosts.
I will let you know certainly if I have the chance, because I'm really interested in going to India.
Wonderful. And so even if something brings you halfway across the world to Europe, I think then it's not too far to come here. So
yeah,
I know
you're right.
it's a very far away, very far distance. I understand that completely. Yeah.
Well, Dr. Krish, it's been a pleasure.
Likewise, great. Thank you so much for spending your time, and I loved talking to you today, and it's great getting to know you.
Okay, I'm sorry that my English is a little rusty, so at times I didn't find the words, but well.
Well, that was not visible to us, so you were perfectly fine. We didn't know you had any difficulty at all. So.
Okay. Thanks a lot.